diagnosis by FNA and it required biopsy. Now we have started the thyroid ablation. So my topic is optimization of thyroid nodule. So I would just like to, before starting my talk, I want everyone to look this article very carefully. So I'll just zoom out the things. So can you make can you read this, at least the highlighted part? So I'll just read it for you. Long-term follow-up revealed regrowth of 80% of patients at the 20-year mark. Consequently, the majority, 70% required retreatment. Do you believe that? So possibly, if you see it's a fake article, the publication date, you see it is 2034. So possibly this is going to be the future article, and that's why the optimizing the ablation technique is crucial for long-term outcomes. So we all know that ablation is going to be effective. We see that the thyroid nodules are decreasing in size. So, but what does optimization means? Optimization means we should, because it's a procedure that we have recently got in last 15 years, and we are very happy about it. At least we have one more procedure in our pocket. But for the long term that it will remain with us, we have to optimize it in terms of very less long-term recurrence, so complete ablation, and also the safety in terms of the patient, the side effects should be, the complication should be less. So let's start what we can do best for thyroid ablation. So basic technique, we all know that it is the transsystemic approach which is used and the moving shot technique which is used. We all know about it. I will not go into the detail, but the advantages is basically you can monitor the positioning of the electrode, you can target the nodule, and also you can save all the important structures that my first speaker has shown. And also when we go through that transsystemic route, you prevent the leakage of fluid part that can cause pain to the patient. Also, it stabilizes the electrode, so the patient, when the patient is somewhat talking or coughing, it doesn't move. And you also able to see the danger area very precisely. You are away from the danger area. Why we do not the moving shot technique, not the fixed ablation as we do in the liver or kidney? Because it is the most of the thyroid nodules are ellipsoidal, exophytic, and also they are very close to the vital structures. In liver, we have margins to save the important structure. Also, if we keep it in the center part and just heat it, the central part will be over-treated and the periphery will remain viable. So, we treat it in the small multiple ablation zones, treating bit by bit. And of course, when we ablate it, because of the gas production, there is posterior acoustic windowing that limits it. So, we have to go to the deepest part first, then come back, and the subsequently more superior parts has to be treated, like in this manner: 1, 2, 3, 4, 5, 6, 7. Like so, when it is moving, we have to be very precise that its tip is within the margin of the target nodule. We ablate for a few seconds and come back. So there are advancement in the devices. So we know the bipolar electrode for pregnant women or those who have electrical devices, they have more predictable size and shape. And also there is also now the virtual needle tracking system are available. I have not used it. Also the unidirectional probe. So one thing I want to emphasize that if you are starting ablation, start with the best of the ultrasound machine, because all these vital structures, my fellow colleague has told you, you are not able to see if you are using a very basic ultrasound machine. You should always have a very good quality machine, and you should have contrast, so that after the ablation you can perform to be sure that you have done the complete ablation. And the virtual tracking needle system, so basically it is attached with a virtual tracking system. You know where your needle will possibly grow. This V part will show the tip, and the dotted part will show where your needle will go. So you get to know where your needle is going. Basically it is important when there is a gas formation, so you know the navigation track, you know where the needle is going. And in cases of large nodule, when it is the posterior margin is not properly visualized during the ultrasound, and of course to save the important structures. Disadvantages is that when you are going through the hard nodules, so possibly there can be some inaccuracies, and also when we put high pressure on the by the ultrasound probe, you can get the wrong path. Also, as we use the CT or MRI fusion for liver ablation, you can also use it for bigger nodules with fusing with the cross-sectional imaging, and you get to know where your needle tip is. Also, for the lesions which are close to the critical structure, there are half moon shaped or 270 degree of insulation where your ablation will be only on a particular direction. So that's how you can save if you find any important structure close by, if you're thinking that. Now coming to the technical improvement. So we do the hydrodissection perithyroidal lignocaine injection that decreases the pain, the comfort of the patient. Hydrodissection critical structures, and also I will come to the vascular ablation technique, that is artery thrust ablation and marginal vein. I will come to it later. So perithyroidal lignocaine injection is very important especially in the anterior part, where you can inject the lignocaine and you have to basically separate the thyroid tissue from the strap muscles. And if you have a good quality machine, you can easily do it by placing the lipidol, and patient becomes very comfortable. This patient doesn't have pain. And also the hydrodissection. So basically you are separating from the vital structures. You save the recurrent laryngeal nerve. Sometimes don't use the lignocaine in the posteriorly because it can lead to the palsy of recurrent laryngeal nerve. And sometimes even with the pressure, some patients may have some voice change during the procedure, but it usually gets over when you have not started the aiding. How do you get to know that? Because it has started before the ablation starts. So usually when you complete the procedure, the palsy goes off. So sometimes the fluid washes off, hydration washes off very easily. In that case, you can add the pentastarch or dextrose and along with that, so it stays more for the hydrodissection. And if you are using RFA, use 5% dextrose. If you are using microwave ablation, you can use normal saline also. Of course, we do it under local anesthesia with possibly even avoid the ablation. Why not GA? Because we get to know the patient, that the patient is having complication. We know that when you are outside the thyroid capsule or any complication,